Hi, it's Kelly English from the Arthritis Patient Advisory Board for Arthritis Research Canada, here in the Arthritis Broadcast Network at the CRA 2020 Canadian Rheumatology Conference. And I'm here with Cheryl Barnabe, Dr. Cheryl Barnabe from Calgary. Can you tell us sort of not the qualifications, I know you've done so many things and on so many different projects, sort of what your title is and now?
Sure.
Okay.
So I'm working at the University of Calgary as an associate professor, and I'm now the past chair of the Quality Care Committee for the CRA as well.
Okay, that's what I thought.
Yeah.
But I better not take a chance on that one.
That's right.
Yeah. So how did you get into the field of rheumatology?
That's a big question. I was actually drawn more to research first, which then led to involvement in some research projects and then involvement in rheumatology research projects when I was a medical student at the University of Manitoba. And the rheumatology group there, so people like David Robinson, Christine Peshkin, Haniel Gabalawi, were all the people that were teaching me and took me under their wing and promoted the idea of being a rheumatologist. It did help that the first CRA I went to was in Mexico, and pretty glamorous life. So yeah, it's been a very, very rewarding career, and I'm just so glad that I was able to find a great home in this space.
Well, definitely we really have benefited from your research.
Oh, thank
Yeah,
you.
and I know many people have. So what are you doing now?
So this past year, I, besides all the other...
Of course, all the rest of the stuff.
research activities. So Dr. Glenn Hazelwood, who's a colleague of mine in Calgary, he's the current chair of the Guidelines Committee. And he's been tasked with updating the rheumatoid arthritis guidelines in Canada because they haven't been done since 2012. And so many of the medications we use aren't even in the guidelines right now. So Glenn, though, has had this great idea to bring in different ideas around creating those guidelines. And so considering not just the effect that we see from clinical trials, but also thinking about health economics and thinking about equity. And so this summer I had the opportunity to supervise a real superstar. Her name's Emily Pianarosa.
Oh, okay.
And Emily came into the project to help us decide how we approach equity in the new guidelines that will come out. So the process that we undertook was first to find out which groups we thought should be prioritized in the Canadian rheumatology landscape for issues of inequity. And to figure that out, we had to do a survey of the membership. We also looked at what other chronic disease guidelines in Canada would speak about in theirs. And then we also did some literature review to see how many of the clinical trials actually talk about outcomes by different equity groups. And there's one study that is super ancient, so that was a dead end. It did not happen. But from the feedback of the membership, from the looking at the other chronic disease guidelines, there were actually 6 populations that we decided were of priority in Canadian rheumatology. And that includes people who are living in rural and remote locations, Indigenous populations in Canada, minority and refugee populations, the frail elderly, people of low socioeconomic status, and also sex and gender considerations.
Those are big considerations. That's a big field.
It was a lot, yeah. But the idea about it is that so there's something called an intervention-generated bias.
Okay.
And so most health service interventions are created for the general population. And so if that has a good uptake in the general population, it generally helps to advance health outcomes for that entire population. But people where the intervention doesn't really work for them don't benefit in the same way. And so you actually end up widening gaps in outcomes if your intervention isn't well thought out. So if we think of guidelines as an intervention, we worry that maybe by saying, we should do this in rheumatology, for patients with rheumatoid arthritis, you should do this and this and this and this for treatment, we may be actually making outcomes really good in one set of the population and making it much worse in another. So how we've approached that was to talk with people, and we're very fortunate to have the Arthritis Patient Alliance and Canadian Arthritis, I'm going to get all the acronyms wrong, but APAP, as well as CAPA, who helped recruit patients. We also recruited health system stakeholders, and we recruited healthcare providers, not just rheumatologists, but also general family physicians, different internal medicine specialties, who primarily work with the populations that we had identified to be a priority. And so we asked them around what were the things that seemed to work best for care delivery in those populations, what were the things that definitely were to be avoided. And then we put that all into a framework of saying, okay, what is it about the population that is different when it comes to just the general characteristics? So if the population has more comorbidities, we may be not wanting to institute the same medical treatment because you have to individualize it. Were there different preferences or goals of treatment? So sometimes frail elderly, the goal is no longer to prevent joint damage in 10 years. It may be to have a really good quality of life for the time remaining in their lives, because it will be a shorter time period than expected.
So, would culture fit into that too? For example, I'm thinking refugee and immigrant population. There must be a cultural problem there too to have to work out, for example. Is there?
We heard that there were some different cultural approaches. So most of the populations that are coming from some of the war-torn countries as refugees, they very much come from a patriarchal society where you are told what to do. And so shared decision-making is a very foreign concept because nobody would ever ask them what they
nobody has for a long time.
What to do. So culture was also as a facilitator. So what we did was understand what was different about the population when it came to arthritis and goals of treatment and preferences and such. We considered around access to care, so both getting the initial diagnosis of rheumatoid arthritis and then being able to follow up consecutively with specialty care. And then we also spoke specifically about medications. And so we asked people to say what were the things that we should think about for this population. And then we took another step of saying, when we go to create the RA guidelines, how do we put those considerations into play, or what are the suggestions that we make to make less of a gap in care through the implementation of guidelines.
And this is a Canadian-wide study, so it will be implemented Canadian-wide.
Right.
That's a huge undertaking.
Yeah.
You don't undertake just little things. And you've already done a fair amount of work within the Indigenous communities with cultural and models of care as well. So that must have helped a little going into it, didn't it?
Absolutely. So it was actually very simple to recruit healthcare practitioners because of how so many Canadian rheumatologists do deliver care to rheumatology populations from the Indigenous community, and lots of great experience that helped to inform how we approached creating the framework and the models for that population.
Sure.
And then we've been fortunate again as well that the Canadian Rheumatology Association is hosting another year of our Indigenous Health Initiative. And so in that, we have again a strong cohort of physicians who will spend Saturday afternoon with us learning all around how to build relationship with Indigenous patients, how to communicate better, how to actually use culture as a facilitator to care. And then we bring them all together again in the fall and spend a full day working on how to train others in the Educating for Equity model.
Now, because we're talking internationally, we reach international crowds for this and patients. Is it true that the Indigenous people or cultures have a higher rate of inflammatory arthritis.
Absolutely.
So it has been proven on that.
Yeah. So we've looked in Australia, New Zealand, the United States, and Canada, and most inflammatory arthritis conditions are at least 2 to 3 times more
not
frequent.
just in Canada.
Not just in Canada. No, it is in all Indigenous populations that we looked at.
Okay, that's new to me.
Yeah.
24 years ago when I was diagnosed, one of the first conferences or seminars I ever took was by Dr. Chris Atkins, who told us about his study of going into the Indigenous communities and how prevalent it was along the West Coast. And it's nice to see that information coming out again. I know you've done a lot of work with Diane Lakai, I believe, but with that,
Yeah.
So this is quite a different model in a way than we've had, where you just treat everybody as the same, I guess,
right,
is what you're saying, because we have.
So a bit more precision, a bit more consideration of what we should be thinking about for multiple populations that are being served by rheumatology. So,
because definitely, and we do have somebody that will be talking to us later, definitely the rural areas have been really tough to, quite something in Europe when you go from town to town to town.
Yeah.
But you don't do that in a place like Canada where, and especially since you have so many Indigenous groups up north.
That's right.
And they need to be reached.
That's right.
Yeah.
That's right.
Yeah. You don't just hop in a car and go visit for an afternoon. No. Well, that's exciting.
Yeah.
And how about with the rest? Are you staying in Calgary? Have you got an actual practice now as well?
I do practice one day a week, all in First Nations communities around Calgary. And there's no plans to change that.
Good.
And we'll be hopefully helping to disseminate a lot of this work over the next year. And we'll also be representing the Canadian Rheumatology Association at OMERACT later on in April in Colorado. So there we'll again be looking at topics of health equity and how we look at patient-reported outcomes and how many have actually been validated in patient populations from groups at risk for inequity as well.
And have you got trainees in the poster session today?
I'm presenting on behalf of Emily because she's out east. So I'll be presenting 2 of her posters.
Perfect.
And I also have a couple members of my research team and a postdoc that are here as well. So
then I will be looking up those posters.
Yeah.
Anita, I noticed that you have some questions.
Yes. Why is arthritis more prominent in the Indigenous communities?
Yes, that is a very great question. And we don't know exactly for sure, but there is some work at the meeting being presented by Liam O'Neill and Hani El-Gabalawi looking at their cohort of patients who are at high risk for rheumatoid arthritis. And what we know is that there are certainly genetic risks that are more prevalent in that population, but it definitely needs other things, and smoking rates is unfortunately one of the issues. Access to oral health care impacts our oral bacteria load, and that can cause activation of rheumatoid arthritis. And then there's also a lot of work going on around the role of chronic stress, post-traumatic stress disorder, mental health consequences. And so all of those things, I think of it almost as a toxic soup, where we've got the right soup base, but then you have to throw in the ingredients, and it just is very, very prominent in terms of prevalence, and then also much more severe outcomes as well, even when you have the best access to care, even when you have all the best medications, we still see outcomes that are not on par with the rest of the population.
Now, some areas, I imagine, distance also must play a bit of a role, does it, with having general practitioners that refer and everything else, getting to that access, I guess. That must play a bit of a role, does it?
It is a factor, but one of the places I work at is actually in downtown Calgary that serves the urban Indigenous population, and even just getting from one corner of the city to the downtown clinic is a big barrier, because people might not have money for
Right.
transportation, or the mobility might be so difficult because we're not on the train line or the bus line, so people do have to walk a few blocks up. And there's so many other things that go on in people's lives because of heightened risk of suicides and overdoses. There's a lot of wakes in the community, and so people are typically grieving and helping support their other community members who are suffered a loss. That, again, it's really, really, the arthritis visit is probably not the priority of their day.
I can appreciate that.
Yeah.
Yeah. Anita, any more questions? That probably covered most of that question. That was a tough one. Thank you so much for joining us. It's always a pleasure to talk to you, and I look forward to seeing the posters.
Okay, thank you, Kelly.
Good.
Thank you.